balloon has atherotones at 3 or 4 places, either you change the direction and then you reuse the cutting. That's the other option that you can do at this point.
Yeah. Sarita, whenever I cut, I do rotate the balloon so that, I mean, you look at things only in 2 dimensions. I try to rotate and see if there are different cuts. So at this point of time, we became a little more, what do you call, I would say, a little more, I used an angel sculpt also. I was somehow not happy. So this is though all of you felt that I could deliver the stent, I was not sure it would expand. And once I put the stent, I cannot remove it, right? So whatever preparation I wanted to do, you can see this, we did the angio sculpt also. There are a lot of cracks, but so in spite of that, I still didn't put a stent. So this is the nodule you can see. I did a IVL. You can still see then OPNNC angiosculp. You can see that the cracks have increased. Then what we did was we took a 412 IVL balloon, as Sarita has already predicted that I may not be able to. Now you can see the waist, Rupali. You can see the waist, right?
Dr. Sujata, this is exactly the reason why I said right in the beginning, you're going to end up using 2 balloons.
Yeah.
And that is the only way I managed to get out of using 2 IVL balloons. 2 IVL balloons in our country, in my sense, means 650,000.
I was like, I was.
The only way to get out of it is an orbit.
There are so many dissections. You can't go back on your strategy.
Yes.
Then you are, you can see that the waist is reduced in size, but not totally. So by then we were reached our point of exhaustion and then decided to stent. I don't know whether it's the right decision. We stented.
I would like to ask here, like if our strategy was IVL followed by cutting balloon and then IVL, rather than as the first pass of 2.5 balloon was smooth, why not the cutting balloon as a first and then IVL?
No, the calcium was too much. It was a nodule. We saw a nodule and a cutting doesn't help the nodule. I use a lot of angiosculpt and all that, but not in a nodule. In a nodule, I do something. I either have to do a rota.
We can, like 2 IVL, like it is sometimes it is very difficult, like to manage the funding.
I was, this is
but
what happened.
Actually, without IVL, we wouldn't have got till here.
Crack the calcium cell. Go ahead.
Because with what happens with cutting balloon is, only if you're
here we have no choice.
Is there any chance? Usually it doesn't. And even if it lands on the nodule, it just cut at one point because they're at right angles. So we don't really achieve anything.
Angiosculpt, OPNNC, no, they don't work in a nodule. A nodule, you have to do either a rota,
either debulking with the IVL or rota.
Rota, or orbit now.
To do a dual. There is a study, a dual prep study, which is going on board, and that would use the combination strategy of rota, whether atherectomy, whether rotational or orbital, plus the IVL, because the atherectomy would debulk, and then this would make the cracks. This combination, it would be the best. You can see, in spite of me doing so much post-dilating and all that, you can see that still the nodule is still persistent. And you can see that there is some plaque shift into the circumflex also with so much aggression. Then we did the OCT.
One more point I wanted to say is there anyone tried of using the 2 balloons at the calcific nodule?
Yeah, I think it's commonly done, Jyotsna. Now with 120 pulses, we should be able to deliver all the...
I'm not asking about the 2 IVL balloons simultaneously. When you are used one IVL balloon and you are producing some cracks, but it is not sufficient enough to have the luminal gain. So anyone has done the 2 OPNNC balloons to further dilate it?
This is commonly done. In fact, Ankush Gupta, he says that after you do the IVL, most of the cracks are only at the basal. Then you should do a high pressure dilatation.
I'm
That's when
saying
you get the good
simultaneous to
MSA.
OPNNC.
Dr. Sujata,
Ah,
Ma'am
Madam
is
is
saying
saying
actually that the
that
two
take two
balloons.
balloons inside at the same site and inflate
okay,
both the balloons
okay.
together.
That way. No. I don't know.
I have seen a one case of the doing that.
Yes, yes.
So that
There's
is
an
rarely
operator
done.
who did it. Yes.
It is rarely done, but that is the way it is helps it, because these calcific nodules, it is not, however you say it, that you release the pulses and everything, you assume that it is going to tackle the calcium selectively and give the giveaway to us, but sometimes it doesn't happen. So that's why, to increase the radial force at that an area for the expansion without any producing a further dissection or the rupture. The major problem, if you go to the bigger sized balloons, the rupture is more likely to occur if you go to the higher pressures. So to prevent that, they use the two balloons of the like a normal bifurcation calculation. What you do it in the same way, if you wanted then a 4 mm size, you take about the 3 and 2.75 of the two balloons and inflate it simultaneously. And especially in the nostril lesions, it is going to be then helpful.
In the same way,
Jyotsna,
the two
Nice,
balloons simultaneously, at what pressures, madam?
It has to be OPN.
Yeah, that's very
That's
something
what I was about
different.
to.
Yeah.
It has to be in higher pressures. That's why, but it is a graded one. It is in your hand to increase the pressures.
Yeah, it is controlled pressures. Okay.
but Jyotsna, do you think that two things are better than an OPNNC? An OPNNC is a double-layered balloon.
Balloons.
So,
that's what I'm saying. Because the problem is the how.
Sujata ma'am is saying two OPNNC.
two OPNNC.
Yes.
My God.
At the same point, yes.
Yes.
I was
has been
shivering
done.
to use one.
So it has been done, and they have shown beautiful results with it.
Okay.
I'm going to do it
I'm
and see.
shivering.
And the
Okay.
diameters, ma'am, could you please clarify how to?
The same thing as a bifurcation lesion, what we calculate is like a 2/3 sizes should be there. And so that's why I said 2.75 and 3 and take it for a 4 mm.
I would be very nervous. Anyway, while
I was not talking in the beginning.
I deployed the stent, as you guys can see that there is a distal dissection, which I covered with a 2.75 15 later, and I post dilated everything later. Okay, so now coming to the point of interest, I got good MSAs everywhere except the MSA which I got was 6.1 at the nodule. I'll show a better view. I'll show the next view. So the distally dissection was there. I covered it. Okay. Because it in interest of our interest is the nodule, I did not concentrate. I did not include that. So you can see that we got good areas. So I was measuring the MSA at the least point. As you can see, it is 6.2. Okay. And the left main and all came 12, 13. So are
And
you
what about the
happy?
circumflex ostia?
See, Hetan, I tried to see it, but I could not, because you would have realized that the left main was a very, very short left main. And
Short
you
left
know,
main,
OCT,
yes.
it's very difficult to get that. You know, you saw there are already, by the time I came to the circumflex ostium, the quality of my picture has reduced. So basically my MSA was 6.2 in spite of all the efforts. So are you guys happy with the 6.2 MSA at the LAD ostium? Though at this point of time, I cannot do anything. A 6.2 MSA at, though we say that anything above 4.5 is good in an OCT, but that is an absolute, having an absolute MSA for all vessels is not right. That's what I feel. A relatively, though the, what do you call, the CAN criteria says 6 is okay, the more recent Excel data and the uni OCT registry, they want areas even up to 8 in osteoLLDs to reduce the MACE in the future.
Did you think of doing the OPNNC inside the stent?
No, I didn't.
Actually, Sujata madam, if you take the OPNNC inside the stent and you dilate it, it works. Why? Because the stent now acts as a cutting.
Yeah. Oh, you mean to say that?
Yes.
As I said, I did post dilatation with 3.5. I did a pot with a 5.8. You can see there was some plaque shift to the circumflex. So I, to be frank, was a bit nervous. By then the procedure went overboard, as you would have seen. So
yes, it will be a prolonged procedure. And
stent distortion, ma'am, in using OPN in a
nothing happens.
No.
OPN does not
I've used
distort because
I
it's
use frequently.
yeah. The best part about OPN is it has a twin layer technology. Now with the twin layer technology, it does not distort and it does not increase in size much, right? And there's literally no dog boning in that balloon. So you can go to high pressures 45. It will open up the nodule. So I routinely do this.
I didn't do it, to be frank, Sarita, I already did all that before. And basically, most of the time, I believe whatever has to be done before the deployment of stent. So that's why I was so aggressive before. As you would have seen, I used all the calcium techniques and all that before. And after that, to me, before I already dilated with a 3, as you would have seen, I went up to 50. So after, as though I do not know this, what you're telling, the stent acting as cutting this.
So Dr. Sujata, I fully agree with you. You did an excellent bed preparation. You used all the modalities. You went with 2 shockwave balloons. You went with cutting. You went with OPNNC. You did a very good job of preparing the bed. But the problem is that calcific nodules don't listen to us. So in that situation, for all our viewers who are listening to us, you've placed the stent and you still see a notch. You only have 2 bailout situations. The only 2 things which can bail you out is an ultra high pressure OPNNC in a 1:1 situation, because now you already have the stent saving you. And the second thing is a shockwave balloon inside the stent once again. Now you've already used 2 shockwave balloons. You can't, take up the cost of the patient anymore. So the only thing which leaves us is a 1:1 OPNNC.
Sarita, I would be very hesitant to use a 1:1 OPNNC. In spite of the stent being there, I would it won't crack it won't do anything on that calcific nodule side. Everything will happen on the opposite side.
Okay. I'll send you a picture.
It works. Sujata, just what I wanted to focus on the same point. OPNNC after the stent deployment is definitely helpful, and it is a different mechanism of that than the usual one, that is known as a focused angioplasty. The major advantage is now the calcific nodule is protruding. Once you go to the higher pressure, the whole of the pressure, the focus of the pressure will be on the nodule. So it is going to be much more helpful. That is first thing. And second one is another advantage of using the OPNNC than other NC balloons. For this is like in the pot, there is a shortening of the shunt is known to occur, which is not shown with the OPNNC. So that's why post-stent OPNNC is advantage than with the other NC balloons.
Okay. But I didn't do it. The other thing I want to point out is post-dilatation. And you used a 5.8, that will elongate the stent rather than shorten it, because every 1 millimeter will be, I forgot the ratio, there'll be an elongation of the stent. I'll post the. Okay.
Agreed, ma'am. After you're going for a very high post dilatation, the trick is you always start from the proximal edge of the stent, where the stent starts. At that time, it's, the elongation part becomes minimum. And I agree with both Jyotsna ma'am and Sarita ma'am, that OPNNC post-stent has a different mechanism. But how much effect it will have on the nodule, because you have prepared the bed very well, that will be again a question, because we are not very sure that where will we have a nodule we'll be able to crack. But trying an OPN will be a good option. But getting a good MSA, because you're getting an MSA of 6.8. So how much more? 6.2, ma'am. Because there was one recent publication in JAT comparing your nodules of MSA compared eruptive nodules and nodular calcification. They said that if you're getting good MSA areas, then these patients are good to follow up. But eruptive nodules despite having the same MSA areas, their event rate after 1 year is definitely poorer. So it's not the MSA, it's basically some thrombotic mechanism or whatever it is going inside, which is leading to these. But I think if a 6.2, and I would have tried just one more OPN and see, and we get a good MSA, it's good. Otherwise, we would have just stopped before not doing much aggressive part.
I stopped at that point of time. And as I said, I got
excellent case, Sujata. We wanted the message from you.
So calcific nodules we know are difficult to treat. A dual lumen wire catheter is useful in wiring difficult osteal lesions. Despite the use of 2 IVL balloons, 3.512 and 412, with all pulses delivered at the nodule, MSA of only 6.1 millimeter square, 6.2. Rotatripsy with a combination of a volume reduction of the nodule by rotablation or orbital, and fractures with IVL may be ideal. And definitely we do have studies in progress. There is what is called a dual prep study, which is under progress. And interestingly, there is a trial, Empower, which is on IVL in women. Martin, what is her name? McEngart. She is the
Margaret McEntigutt. Margaret McEntigutt is the principal investigator. And she's joined by Alexandra Lansky.
How come you guys, you're not in the center?
Because they didn't involve Asia. I was at that meeting at EuroPCR where they had a women's meeting. The Shockwave people had a women's meeting, and I was representing Asia Pacific region. But they planned this trial, but they did not involve Asia Pacific.
So that's what I wanted to ask you why. That's why I included that slide.
We'll have to ask those people why they don't involve Asia Pacific. In fact, I even wrote to them that maybe you should have a trial in Asia Pacific women, because you see Asia Pacific women would possibly behave differently, because we are the ones who have the smaller sized arteries. We are the ones who have the smaller sized women. And that's where you're going to look at good outcomes with Shockwave versus other atherectomy devices. They said they'll talk about it, but they haven't, done anything about having a trial in the Asia Pacific for this. Maybe we should all as a group push them to have it, because it seems a little kind of unfair that they would plan this study for non-Asia Pacific zones and not for Asia Pacific.
Yeah. So basically, Disrupt study, the women arm, they did show that women did well.
Yeah, the women did better because it was a balloon-based therapy, and they said that there was less amount of trauma, less amount of complications, and women having smaller sized arteries, they did better with this therapy rather than with the rota and orbital and all, which is to be expected. But then unless we have a study and we actually have data proving it, we can't say that it applies to our Asia Pacific region.
The other reason, see, interestingly, this lady was only 50 years old. And look at the amount of calcification which she had. And I think we should try to do a study in Indian women of IVL. Okay.
Yes, I fully agree.
Excellent, excellent. Each step is educative. And it is not possible to do so daringly. It is daringly easy to give the advices after doing the case.
Tottering on a nervous breakdown, I was.
So it's a very well done case. Excellent.
Wonderful case. Dr. Sujata, excellent case.
Very well done case.
I would say at the end of it, and a good expansion and good opposition of the stent.
No, I'm still, it's only 4-5 months. I'm still waiting with bated breath. I tell a cardiologist should get pass marks only after 6 months. Okay, right.
Okay.
I'll post the short video of it, okay, in the group. Right?
Thank you. Anyone want to add anything?
I think it was a beautifully done case, ma'am. I was just imagining you opening balloons after balloons, and
I got some leeway. They gave me one shockwave balloon.
But I mean, now that you've used a double lumen catheter, if you could just I mean, it's good for osteal lesions. So, ma'am, what's your experience? I haven't used a double lumen.
There are very good uses of a dual lumen microcatheter. For example, wiring like this, I always find it very useful. So you already wired the circumflex, right? You will have an what do you call over the wire arm and the monorail. So I wired the circumflex. On it, the monorail goes. You place the catheter there, and then you through the over the wire lumen, you pass this wire. So this is very useful in all the tortuous things. Especially Rupali will say that for CTOs, for the parallel
I was going
wiring.
to add. So there are two reasons, ma'am. One was that your hole gets redirected towards the ostia. So once your hole is towards, you are able to direct it. Second, it was a plus minus 100 type of a lesion. So it will increase the strength of your wire. The tip load of the wire increases whenever you put on a micro catheter. So these two things with a dual lumen catheter, we have already Crusade available. We don't have a Sasuke at present. But it really helps in, So XTA, which was not able to go with the fine cross because because we were not able to take the micro in the part. The side hole will really help you in increasing the tip load and redirecting the wire, man.
So I've used it for
I will advise all of you to read about this
I will post one more on dual lumen microcatheters. It came in Intervention. And the other thing I wanted to, there was an interesting thing that you can use it for delivery of drugs in what do you call in semi situation. I didn't use it. I
did it once. I did it once when GP2B3 had been empty distally, but
you can use it, right? Helpful. You can put the thing and you can use it for the over the wire lumen for delivering the drug. So that's one more place you can. Okay.
Actually, there is a one full article on microcatheters in our IJCDW. The varieties of the microcatheters, all the three varieties of the double lumen microcatheters are with the figures are given in that. Please, I will advise all of you, the students to see that article.
Can you post that? I'll post this in Intervention and I'll post the video. Okay.
Sure. I will give that link. Yeah.
Okay. Thank you. I hope you all liked it. Despite of my late start, I was.
We forgot that late start. You just reminded us, ma'am. We had forgotten. It was so.
But it was a very learning case. I think the best part which you mentioned, your bed should be prepared. Irrespective how many balloons you open, if your bed is prepared, you will not regret
then
later.
I put the stent. Generally, that's my rule.
Yes,
okay.
Very
That's an amazing case by you, Dr. Sujata. The past, I think, half an hour, the way that it has gone with the very exciting discussions, the points of learning have been tremendous. And it was an extremely interesting discussion of all the modalities available for dealing with such calcified nodules and calcified lesions, the various kinds of hardware which you can use for wiring and to increase the tip support. So I thank all the panelists. I thank all the experts for their expert comments. And thank you so much.
Thank you. Thank you, one and all.
Thank you.
Thank you, ma'am.
Bye-bye. Bye.
Bye.
Bye-bye.
Bye-bye.
Good night.
Bye. Good night.
Recording stopped.